Okay, Assalamualaikum warahmatullahi wabarakatuh, and very good morning to everyone. Thank you very much for the organizing committee for inviting me to be one of the speaker for today. And thank you very much also to make sure that this BEFS to happen today. So I think there is a overlapping in terms of what you call that lecture by Dr. Vaish yesterday. I wasn't attended. This is what as Mas told, and Prof Aisha alert me. Oh, there is a such thing as early treatment for for HER2 negative. So I just add on a bit about triple negative breast cancer. Whatever that overlap, just make it as like a refresher for all of you guys. So I'm not the expert in terms of systemic treatment. When you talk about systemic treatment, whether chemotherapy or targeted therapy or immunotherapy, but what I will highlight today is what is the role of the surgeon, you know, when you talk about the HER2, you know, and early breast cancer for triple negative and HER2 enriched breast cancer. So because why? Previously, as what we normally do, because there is a paradigm in a treatment paradigm change, you know, in such a patient, you know, as what we know that a neoadjuvant chemotherapy previously is just for non-operable tumor to make it operable. That is what generally we know, right? So, but nowadays, because of the NSABP B18 and 27 established that there is no different in terms of chemotherapy efficacy in pre-operative as well as post-operative. So because of these results, it changed the treatment paradigm from upfront surgery for early breast cancer to neoadjuvant chemotherapy. So early breast cancer, as been defined by the National Cancer Institute, is a cancer that has not been spread beyond the breast and as well as the axillary. As what is included in National Cancer National Cancer Institute is ductal carcinoma in situ, stage 1, stage 2A, and stage 2B, as well as stage 3A, includes the T3 and N1. But in our CBG, it's a bit different. There is no T3 and 1, there's no 3A. So this is what I got from the updated definition. And as you can see, the classification of breast cancer into biologic cancer, and from this picture, you know, it's just for our basic knowledge. This is the cross-sectional on your right-hand side, is a cross-sectional from the terminal duct lobular unit. You can see there is a different type of cells, you know, and you can see there is a luminal cells or epithelial cells and also basal cells. Because of this different type of cancer, that's why if any abnormality from that type of cancer, there will be a different type of cancer that you can have from luminal A, B, HER2, and triple negative. And what you can see in terms of the histological grade from luminal A compared to the triple negative, you can see the triple negative has high grade in terms, it is high grade, which is grade 3, whereas for luminal A, which is indolent tumor, is most of them is low grade tumor. Why is this significant? Because it prognosticates the tumor itself, whether this is poor prognosis or is it very good prognosis. And it also helps, and it also prognosticate whether this tumor respond very well towards a chemotherapy. As you can see, triple negative, respond very well with chemotherapy versus the luminal A. As you can see, it's only, most of them is just respond with the endocrine therapy. And what actually all of you have learned yesterday is about HER2 is a human epidermal growth factor, or also known as a CD340, is encoded by the CERB2 gene in a chromosome 17, 25% of all the cancers. And how to diagnose, as what everyone knows, is when your HER2 is overexpression, or we call it a 3+, or there is a positive from the gene amplification or each test. And this HER2 is associated with the adverse prognosis or worse prognosis, and have a very, very high risk of recurrent. Whereas for the triple negative, everyone knows ER, PR, HER2, there's no expression of all these three receptors, and it account approximately about 10 to 50% of all the breast cancer. And in 10 to 50% of triple negative breast cancer, 70 to 75% is basal-like breast cancer, because as what I am showing just now, right, there is epithelial cell and basal cell. So triple negative is actually arise from the basal cell. Okay, so what have been recommended, how this treatment change is started from the ESCO guideline, and as well as the St. Gallen International Consensus mentioned that is more of 90% of them agreed that for the triple negative breast cancer, as well as HER2 negative breast cancer, stage 2 to 3, it should start with neoadjuvant chemotherapy. That is what a guideline said. And then what we already know, that a preoperative systemic therapy or neoadjuvant chemotherapy is, first of all, the benefit is to facilitate for breast conserving surgery. It increased uptake for breast conserving surgery. And next, it will cause, we can render, as what I mentioned, most of the time we will send a patient for neoadjuvant chemotherapy to make it operable, right? And next is to check whether the patient has responded, to the treatment, then we can prognosticate further. And if a patient did not respond, or if a patient has a residual disease, we can add on, or we can supplement some more treatment in adjuvant setting. And as what we know that because neoadjuvant chemotherapy, normally it takes like about like 6 cycles, so times 3 weeks, so it's about 18 weeks, right? So 18, it allows us for the genetic testing, but as what Prof Aisha mentioned, nowadays we can only 1 week already we can get a genetic testing results. And it's also allow for us as a breast surgeon to plan what type of reconstruction for the patient, and also to help a patient to make a decision for the type of surgery. Sometimes you can have a patient who is undecided what type of surgery, so at least we can subject patient for neoadjuvant chemotherapy first. Okay, I noted that. and this is from NCCN guideline. The latest one is again, they highlight about the selected operable breast cancer, which is early breast cancer, should be offered, you can see here, for the T2 or N1 positive HER2 and triple negative breast cancer, and preoperative or neoadjuvant chemotherapy for okay, for preoperative systemic therapy can also be considered, in T1C. So when we talk about stage 2 is 2 cm and above. This is, we are talking about T1C. It means 1.5 cm, or with a note negative, we can also consider for neoadjuvant chemotherapy. So in the NCCN guideline actually guide you how to when you to manage a patient with before the neoadjuvant chemotherapy. As you mentioned, these are the list of the patient that is eligible for neoadjuvant chemotherapy, and with the MDT decided whether patient require CT scan or not. As what we know, early breast cancer not necessary to proceed with a CT scan, but somehow in some patient you might need to have a CT scan, or might need to assess the axilla properly. And then in some circumstances where the patient decided for breast conserving surgery, please make sure that you put the clip in the center of the tumor itself before the chemotherapy commences. And this is why, because with the neoadjuvant chemotherapy, we can achieve a pathological complete response. I think yesterday it's already mentioned about this. And this is basically the absence of residual invasive component. It doesn't include the what you call that DCIS. It's just a residual invasive component. If there is none of them in breast and axilla, we can call it as a PCR. And this is also, PCR is also a strongest marker for a long-term disease-free survival and a lower local recurrent rates, mainly for triple-negative breast cancer and also HER2 enriched. And when you talk about PCR, the clinical response rate for neoadjuvant chemotherapy, so there is two different things. This is clinical response rate is about 50 to 85%. And when you talk about PCR for triple negative, is a bit lower than a HER2, which is about 15 to 40%. And for HER2 is about more than 50%. And with this PCR, it helps in terms of BCS rate uptake. For the TNBC, about 25 to 40%, and then for the HER2 is about 60%. It's quite high, where we can subject a patient for breast conserving surgery. I think this is already like, been taught, we've been lectured yesterday. So as you know, this is from the ESMO guideline. It recommended for adjuvant, regardless of adjuvant and neoadjuvant chemotherapy, the targeted therapy must be commenced about 12 months with a cardiac monitoring. And a neoadjuvant setting, is agreed upon ESMO guideline, SEN guideline is everyone with a stage 2 to 3 disease for neoadjuvant chemotherapy with anti-HER2, where we have nowadays Herceptin and also Perjeta. And the different type of chemotherapy that we have, but for this HER2 chemotherapy, for HER2 enriched, we use anthracycline, taxane, or taxane carboplatin, And then, of course, dual blockade is better than only one, targeted therapy. So, once a patient settle with a neoadjuvant chemotherapy, there is a form of adjuvant treatment for the residual disease. For the non-PCR, what ESMO guideline suggests to add on the TDM1. And for some patient who is a stage 1 disease, say the approach where they start with a surgery first, followed by the adjuvant like paclitaxel and the trastuzumab for 1 year. And for the pathological stage 2 and 3 treatment with initial surgery, so the adjuvant treatment, the chemotherapy will combine with anti-HER2. And note positive, you can consider to add on the Perjeta in adjuvant setting. So for treatment for triple negative, it's a slightly different. As you can see, it starts from T1C. When we talk about HER2, there is a 2 there, right? So is for HER2 is stage 2, and it's T2 and above. For the TNBC is T1C, 1.5 cm and above. Okay. And of course, for the stage 2 and 3 is neoadjuvant chemotherapy. It should be treated with pembrolizumab. As you know, pembro a bit expensive here, and they actually pembrolizumab can be used as a neoadjuvant or adjuvant treatment. And there is also additional treatment whereby that is what mentioned in a patient with BRCA mutation positive. You might consider olaparib, and as well as whoever that has a residual disease, capecitabine can be used for adjuvant treatment. Okay, so this is actually the gist of my lecture. What should a surgeon should know about this is first and foremost, we are the gatekeeper. We should identify who is this patient. I think this is our take-home message for today. Which patient that has a HER2 and triple negative breast cancer, this is overview that I highlight. HER2, there's 2 there. So just remember T2 and above, you can consider neoadjuvant chemotherapy. Whoever had not positive in HER2 also can consider for neoadjuvant chemotherapy. Whereas in triple negative breast cancer is CT1C, which is 1.5 cm and above, or anyone with a not positive diseases. Once we identify, of course, we need a comprehensive workup, as what I mentioned, auxiliary assessment, staging, and before we can plan our surgical decision. And this is very important before you recommend a patient, before you can, meet up for MDT. You have to assess yourself whether what type of surgical type of surgery for breast as well as axilla for that particular patient. Because it's very important, if you decide for breast conserving surgery, you must place a tissue marker. And then once we gather with the oncologist, once we gather, then the decision made for neoadjuvant chemotherapy again and again, because these are the things that we might miss, during the period of neoadjuvant chemotherapy. We arrange during MDT, but then we forgot later. So no one arranged, and then suddenly patient come to you without the tissue marker, and then you decide, then if there is a PCR, you cannot do anything. You just have to must take a patient, because we don't know where is the lesion. And we also do, we should do a mid cycle and post cycle assessment, where to assess whether the tumor respond to the chemotherapy. And post neoadjuvant chemotherapy, as what UMMC practice, we always repeat a mammogram and ultrasound before we commence for surgery. I think that's all from my presentation. I think a bit boring because a lot of words and a lot of facts. So I hope that you can, you enjoy my lecture. Thank you very much. Just to remind you, I'm a breast surgeon. Don't ask systemic chemotherapy best option or what. Okay, you have to understand, when we talk about early breast cancer and metastatic breast cancer, this is two different topics to discuss first. First, we have to decide if this is metastatic disease, is already palliative intent. Whatever treatment that you give, it's always been palliative. Whatever decision you made is for palliative intent. Whereas for early breast cancer is totally different, is for curative intent. Whatever pathological response happened to this metastatic breast cancer, so we don't proceed to, oh, okay, this patient is good, there's pathological response, so we subject patient for surgery or so on and so forth. So this is always need to be MDT, it depends. Some metastatic breast disease with the oligomets, sometimes we still subject a patient for surgery, as in some cases, for example, like young breast cancer, in a Turkish trial, there is a, what call that, chance for you to do a surgery. But bear in mind, before you decide that, you have to sit down to do MDT to decide with the oncologist whether it's worthwhile to do any further treatment or not. Because the decision is always made by oncology, because this is already palliative intent. It's no more curative intent. And if you were to decide in terms of treatment like a surgery, it's always need to be MDT decision, and it is case by case basis. Yeah.
Hi, I would like to ask regarding breast markers. Immediately, because you're talking more on HER2 positive versus triple negative, but I would like to ask regarding RPR also. So there are cases like early breast cancer where we want to project the patient for neoadjuvant chemo. When is the perfect duration to actually do the to insert the breast marker?
Okay.
Because as I'm just want to know, because as I said, the triple negative and HER2, they respond better with chemo. So that means you need to insert it a bit earlier, perhaps before the first or after the first cycle. How about the RPR?
Okay. Yeah, very good question. And what we normally do, what we normally practice in UMMC, regardless is whatever status of patient has, if the decision is already made for breast conserving surgery, we normally put a tissue marker prior to neoadjuvant chemotherapy. Even earlier, if you cannot put it before because of the appointment or so on and so forth, we at least put during the first cycle or second cycle, regardless whatever patient whether has a HER2 or ER/PR status. That is what we practice to ensure that we don't miss a patient. We never know, we never know. Of course, we know that a chemotherapy response for ER is much way, less compared to the HER2 and triple negative breast cancer. That is the safest way to do once you decide. As what I mentioned, once you decide, please make sure that you put a tissue marker in the center of the tumor. Yeah.
I have a question. You see the triple negative patients T1C 1.5 cm to be subject to measurement. Is that standard for all your patients or just some select patients?
It is standard. It
Standard
is,
for all
yeah,
patients.
that's the reason why we have this lecture today, to just to highlight everyone, to update everyone in such cases, even 1.5 cm, if it's even operable, please, discuss, sit down with your oncologist, and you can actually subject for neoadjuvant chemotherapy. Why? The benefit is we can actually achieve PCR. If there is there is a residual disease, we can have add on a supplement adjuvant treatment after the
And is it across
neoadjuvant.
similar?